Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. We have Chris Mastrangelo here with us this morning. Many thanks to Chris for joining and taking on this great information, this great presentation. I do have a few quick updates to share before we get started today. This webinar is being recorded and will be made available on the PHCA website within the next 2 weeks. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided a NAB number, credits will be uploaded shortly. We'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. So please feel free to submit your questions via the Q&A icon on your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. Now I'll turn today's webinar over to Chris.
Thank you so much, and thank you to Pennsylvania Healthcare Association. You guys are the best. Your updates are phenomenal. I don't say that to everyone. I have to say that you're amazing. Your group is outstanding. Thank you for having Harmony. Today we have 60 minutes for the grade 8 fiscal year 2023 leadership and motivation. I have been on the road for 22 days. And I've spoken on this quite a bit. I want you to know that the PowerPoint that you have is filled with information, and information that I will not get to, or let me say this, I will get to it, but it's deeper, so that when you go back to reference it, you're going to have sort of the how and the why, and just a little bit more content on that. I will spend a lot of time on the first slide. The goal of this program is to give you the top 8 areas that you should focus on as leaders. And I say that in the context of I'm a nursing home administrator, I'm an OT with a dad that is a mathematician, rocket scientist, so I'm an OT that can count. And I'm all about finding, distilling, sharing with you, and prioritizing so that you can do your day job. The amount of time that I spend on regulations and changes and distilling and synthesizes is a full-time job. So as I always start with one out saying, I wear 20% of my clothes 80% of the time, as do you. In the world of management, in the world of operations, 20% of your efforts give you 80% of your results. So therefore, it is critical to know what those key components are, because we could work for 24 hours a day and miss the mark. Not uncommon. So my mantra has always been fill the beds, collect your money, give good care. Fill the beds, collect the money, give good care. So today's 60-minute session is going to be Twitter on steroids, giving you the 8 top areas to look at, which they are going to diverge into a little bit more than 8, but that's conceptually where you're at. And we're going to talk about customer service and person-centered care, and there's some anecdotal stuff that I have for you there. So we're going to get started. I'm going to stay on this slide, and I'm going to do this faster because this can take me about 90 minutes. But because I've spoken on it so much, I think I can perfect it. So, but right here, see these top 8: compliance, analysis, audit, regulatory, rehab, reimbursement, efficiency, and survey. Those are always the 8 categories. Underneath them, I'm going to give you the priorities. Now, before I even start, I can say to you that the number one thing that you need to be focusing on is between today and the end of October are the 7 areas that the ROP from June 29th, 2022, which is a revision of phase 3, which was delayed because of the pandemic. And it is basically, you have to train yourself, your staff on compliance, QAPI, resident rights, infection control. I said resident rights, QAPI, communication, QAPI, compliance, and I have a list for you. But the point is that it's going to take far longer than 30 days. So I just wanted you to be aware is you have to educate and train. The common theme around this ROP is that the government is looking for competent care providers. I understand that there's a staffing crisis. I understand all of the challenges, and I commend all of you for still being here. That is demonstrative of your resilience and commitment to the senior care population. So of all of these things, the hyper focus on, can we get in motion the elements from the 62922 requirements of participation, because there's a lot to do on that. It takes me 8 hours just to tell you what to do. But in those, you've got arbitration agreements, you've got, the focus on QAPI and how you're creating and developing your metrics. You have the resident rights with regards to if you have e-cigarettes and allowing those to smoke in a nice area, and not if you're going to turn to cessation of it in a smoke-free environment. There are lots and lots of pieces to this requirement. So now we're going to refocus and we're going to go to number one, compliance. Now, first and foremost, there are 7 elements. I will get to that slide because you have to know those 7 elements in the concept of being trained between now and October 24th to 25th. Before I go there, I'm going to jump to the OIG Managed Medicare. Now, how it rolls is this. Managed Medicare is an entity that comes in that takes traditional Medicare and oversees it in an effort to save dollars for the government. These entities have been around for decades. These entities essentially cannot change the rules for the coverage criterion for Medicare, but they will be involved with you far more frequently than if it were a traditional Medicare Part A. The first bullet, OIG Managed Medicare, is a report that came out that identifies between the 13 and 18% error rate on denying Medicare benefits to those residents, beneficiaries under those programs. So my number one area is that if you have managed care contracts, I want to make sure that you sit back and take a look and ensure that those contracts are fairly treating the beneficiaries that have signed up for those. I'll give you a quick story. So, and this was within the last decade, I was in a Massachusetts building and I was reviewing patients. We do monthly audits and I'm reviewing them. And then I'm like, oh, what's on that unit? And the administrator said, well, those are our managed Medicare. I'm like, oh, how does that roll for you? He's like, well, we don't have the 3-night qualifying stay. And if they become skilled, we call the nurse in Texas and then she'll guide us and they'll put them on Part A. Okay, so I go, can I just peek in some of those records? Because I'm all about the medical record review. So he's like, of course. So I go over and I look at a few records. Well, the first record is a patient that the nurses identified had pneumonia because of body aches, because of fever, but the nurses on the unit had no idea that they needed to communicate to someone, but they did provide the skilled services to identify it. So after I identified it, I told the administrator, and he then called the Texas nurse, who then said, yes, absolutely, they're on Medicare Part A, effective today. And of course, I say, well, what do you mean today? The last 4 days, 7 days, they have been observing and assessing the patient for skilled care. So that's curious, right? Well, same facility, I then go to patient number 2, who is now a G tube. And this particular patient is consuming everything through the G tube. Well, if he's consuming everything through the G tube, but they denied his Medicare Part A benefits after 20 days. So I said, well, why did they deny that person Medicare Part A? Well, I write my report and I don't know, 5 days goes by, they call me up. Hey, the nurse from Texas is coming in for lunch. Oh, can you come over for lunch? I'm like, absolutely. I call it the $13,000 lunch. I sit next to the Texas nurse and I say, why did you take Mr. Jones off Medicare Part A? He was a G-tube and he consumed 100% of his food via G-tube. The rules of engagement are that if 26% of total daily caloric intake and 501 milliliters or more are consumed through the G-tube, they are skilled. And you know, their Medicaid rate is a whopping $179. And the difference between that Medicaid rate and the Medicare Part A rate is $13,800. Crickets. Put them back on Part A. The example is that managed Medicare cannot change the coverage rules. So take a strong look if you have any of these programs within your organization. And the OIG, who is the Office of Inspector General, has given recommendations to CMS, and they are further investigating this. So that's number one. Number two is the 7 elements of an effective compliance program. Now, that is going to be the last 2 slides that I will do, because I'm going to give you some big details on that. But at the end of the day, the compliance regulations have been in the Federal Register for long-term care since 2001. They've been there, recommended. This is not new. This is now being officially mandated. So, and in order to have an effective compliance program, people will call me all the time. Can you assess, can you observe? It takes me 3 minutes. I walk into your building. I randomly go up to someone and I say, do you know who the compliance officer is? And if they don't know who the compliance officer is, you don't have an effective compliance program. So a compliance program is critical for you, because if and when things go sideways, which they will, the government wants to make sure that you have attempted, because things can go sideways and they will, but to make sure that you've attempted and you've put in the infrastructure and the culture to identify it, and upon identification that you react, investigate, mitigate, and prevent. Prevention is identifying and prevention, the key elements. We're going to go back to that. Analysis. So we have 2 things under here, 5-star and quality measure 5-star. Let's take it real simple. PBJ. You are submitting your hours to the government for your 5-star quality rating system that has 3 domains: staffing, quality measures, and health inspection. As of July 1st of this year, it has changed, and your rating is going to be on not only your HPPDs, hours per patient day, it will also include turnover of staff, weekends, nurses, and administrator. Why? Because studies have shown that continuity of individuals provides better care, and continuity of leadership provides better care. So my point here is threefold. Number one, make sure that you are submitting the proper information. Number two, that you know your goal HPPD. Let's take this down a little bit. When you submit your hours, there's a calculation that occurs that adjusts it. That adjustment is based upon your MDSs submitted, their level of acuity, for lack of a better word, their CMI. And every quarter, this adjustment changes. So the change, and I have whiteboards all over my house, the adjustment changes. So I've been working diligently to have like a predictor model, which I've done, and for free. And if you are happy to email me and I'll just run it, you just give me a provider number to know what should you be looking at, what should you be staffing at. Understand that it's a prediction. Understand that because the adjustment is based on the average of all 14,000 nursing facilities once they submit, but you have to have some ability to plan. Now, that's the one fold. The two-fold is that the one fold is make sure what you submit is accurate. The two is that you know that turnover is now being implemented. It started July 1st. And so that's number one, that's number two. And number three is that you can only get a 3-star at most with perfect HPPD. Let me say that again. Your hours per patient day will impact, if you are perfect, the best you can, and you have horrible turnover, the best that you can do is a 3-star. So now what that means is your PBJ staffing domain is, a portion of it is going to be attributed to your staffing, and the other portion is going to be attributed to turnover. That's that first bullet. With regards to, it says quality measures. As I mentioned earlier, you have your quality rating system. It's public. There are 3 domains. You have your staffing, health inspection, quality measures. Leaders, there are multiple quality measures out there. I want you to have a little bit of a vantage point. For the 5-star quality measures, one of the 3 domains, right? There are 15 quality measures. For the QRP quality measures, there are 13. Excuse me. There will be 15 in the QRP 2 years post end of PHE, public health emergency, which we'll get to. So, number 2, PBJ calculation has changed. Validate you're submitting correctly and understand that turnover is now involved. Quality measures, F5-star, 15, because in my opinion, the quality rating 5-star system, the nomenclature can be confusing. You may go to the meeting and say, for a 5-star quality rating system, we're a 5-star. We have these domains, but you could be talking about my quality measure domain, my 5-star, and people around you may be confused. So it gets to be, my goal here is that you understand that when you're sitting in a room, people may not be talking about the same subject matter because the nomenclature is a little bit off. The 5-star quality rating system should be, oh, you know, under the staffing domain, I have 4 nuggets. A different word because it can be confusing. So, number 3, audit. TPEs are targeted probe and education. And we have seen these throughout the years, and they could be called different things. PERMs, RAC audits, medical record review, help letter, ADRs, additional development or additional data requests. This is a high sense of urgency for you. I want you to go back, talk to your business office manager in the common working file, if there is anything in there. So the TPE stands for Targeted Probe and Education. They're going to request 20 records. Those 20 records, they're going to ask for certain elements of them. The TPE could be prepay or postpay. Either way, it's urgent, but if it's prepay, it is more urgent. Why? Collect your money. They're holding up your cash. You got to make sure that you have cash to run your business. They're going to ask for 20 records. And then they're going to review them. If they find that there are errors and you have an error rate greater than 15%, they're going to put you to round 2. And if there's a 15% error rate, they're going to put you to round 3. And if there's still an error rate, you're going to go to CMS and you could lose your provider number. My recommendation is that you go to your buildings and ensure that check to see if you have any letters and notices. If you do, immediately create a spreadsheet with the names of the patients, the dollar amounts, the dates of the claim, and get a system established to get these letters out, the information out as soon as possible. 14 years ago, I created what I call the PrEP letter. When you submit this to the fiscal intermediary, it's the old name, FI, the MAC, the contractor, you want it to be beautiful. You want to have a letter that talks about why they were skilled, give the rationale. You want to have attached to it all the information that they requested. You want to number those pages and submit them. There are instances, well, let me stop. If they deny, you can appeal. There are 5 levels of appeal. So you want to take high focus on why did they deny it? Is it appealable? And how long do you have to appeal? And you have time, but I do put this on the top priority. So, and there's a lot more to say upon that, but I just want you to know that, to be aware. Now, QRP, there are different types of quality measures. And just so you know, there are 3 different quality measures for hospital readmissions. So when you're speaking about quality measures, understand what are you talking about. And there's a concept also known as value-based purchasing. You currently have value-based purchasing. There are 3 components to value-based purchasing. There's a metric, there's a report, and there's a reward. The metric for you right now is, do you know? The metric is hospital readmissions. And the reason for that is because through intensive studies, the government has found that, they have found that residents, patients that go into the hospital are at their greatest risk because of HAIs, that's health-associated or health-acquired infections, from catheters, from staph infections, from bacteria. So they're actually safer not being in the hospital. With that said, the government has implemented this value-based purchasing model on you to track the number of patients that leave your facility and go to the hospital. That's the metric. What is the report? Well, the report is your nursing home compare. And nursing home compare is available to everyone. And the concept of value-based purchasing is that there's an external motivator. Something else is pushing you to do something. Like, for example, when I get my electric bill and they bar graph my electricity compared to my neighbors, my bar graph is way up here and my neighbors is down here. Well, I have 4 daughters. They blow dry their hair, the lights, etc. It's a concept of, we're going to nudge you to behave in a certain way because we have studied and found it's best practice for the consumer's interest. So it's all about transparency in the consumer. So VBP, value-based purchasing, number 1, metric, rehospitalizations. Number 2, report, transparent, all available to all, nursing home compare. Number 3, reward or penalty. If your hospital readmissions is above, and I'm guesstimating right now, 14%, you will pay the government 2% of total revenues October 1st. So if you bill out $100,000 a month, 1.2 million a year, and your hospital readmissions is of greater than 14%, you will be paying them $24,000 October 1st. If you are billing out $1 million a year for Medicare Part A, you will be billing out, you'll be giving them, and you're above 14%, $240,000. Is that a lot or a little? I don't know. That is your money concept. It's how you are raised. It's about your business. But I'm bringing this to your attention because customer satisfaction, person-centered care is a high focus of the government. And it also goes into the fact that value-based purchasing, it will be a metric of VBP. So for you to know that in one of the 7 areas for you to be training on is called behavioral. Under the behavioral module is trauma-based care, person-centered care. The ability for the nursing facility to understand how to care for said patient. Now, I'm going to do a little story, and because it's all intertwined, I was, always the phone call. I'm always the crisis manager. The phone call comes in, and there's a crisis. Oh, let me back up. This was a current client, and the Harmony team was out there, and they had a sexual allegation. So on a Saturday, I get an email from the owner saying, "We need you out here." Okay, I fly way, way out. But the team had given me the heads up that, they have this sexual allegation. And they are hyper-focused on the fact that it did not happen here. I said, okay. I walk in, my first day, I walk in and I have all the management team, and I said, and I got the same exact feeling, and I said, look, if I open up a barn door and I see a snake, I go into fight or flight. It's a central nervous system response. My pupils dilate, my heart beats faster, I have adrenaline, I see a snake. And that's how I feel. I look again, and it's a rolled up piece of rope. Oh, it's a rolled up piece of rope. So it did not negate how I felt when I thought it was a snake. So this facility, I said, regardless of whether or not you believe that it happened here, the resident believes it happened here. So immediately, tout suite in French, we must train every person on trauma-based care and how to do that. For example, if someone comes in with trauma, first and foremost, anyone with trauma requires control over their environment. And here is control, meaning, do you want to stay in this room? Would you like to have your own room? Would you like to be at another facility? We're only going to have female caretakers. When we're near the elevator, we are going to give this resident control over if they want to be on the elevator without anyone else. And the list goes on. The government has said back in 2016, hey, skilled nursing facilities, nursing facilities, long-term care, you need to not only be able to identify when and if a resident is coming into your nursing facility with a DSM-5 diagnostic statistical manual. Examples would be anxiety, depression, schizophrenia, bipolar, autism, ADHD. You have to be able to identify the trigger and how to manage it. In other words, you need to know what happens to that person and how to placate it and make it sure. It could be a sound, it could be a smell, it could be a person, it could be a touch. Anything can trigger an individual. Now let's pause for a second. A DSM-5, 5 out of 10 United States citizens will have a DSM-5 in their lifetime, and that's, say, those that go to the doctor. So let's just say it's 7 out of 10. this is not in a scarlet letter. Well, let me rewind a second. I'm thrilled that the government is identifying this because it's mind, body, all of us are affected by our minds and our mental health. So I don't want mental health to be a scarlet letter. And as an occupational therapist, I am quite aware of the impact and have been trained on it. So the key is that the staff understands, okay, if something is going on with this patient, we have to care plan it, write it, discuss it. Now, in order for us, them, whoever, to not get a DSM-5, they must have coping mechanisms. Coping mechanisms could be running, walking, yoga, Pilates. It could be Netflix. It could be painting. It could be anything that that person uses to problem solve and get their nervous system settled. It could be a glass of wine. It could be a bottle of wine. It could be a liter of vodka. The government is saying, in the context of person-centered care, we do not want you to judge. So when the resident is coming in and you're going to be non-discriminatory, you are not going to be questioning their culture, their religion, their race, their sexual identification, any of those things. You are going to talk about their journey. In 2017, a nurse called me and she said, they want me to admit this patient he drinks a liter of vodka a day. He won't go to AA. And she's like, I'm not admitting him. And I said, listen, Akute, listen, you are not the judger. You need to find out his story. If he's drinking a liter of vodka, there's a reason for it. He's had trauma. And you need to find out how you can help him. You cannot judge him. You need to find out his story. No judgment zone here. And that is something that has to resonate through your facility. Being able to extract it out. So number one is culture. Number two, person-centered care, trauma-based care, education, and ensuring that the staff understand the empathetic process that can occur. And this is a whole different session. But it is about understanding that person-centered care is driven on the person's needs, desires, not the operations of the facility. Which, by the way, that's hard because your whole careers you've created. Okay, we've got breakfast from 6 to 8. We've got lunch from 12 to 2. Person-centered care is on demand. It's, I go to bed at this time. I want to eat this food at this time. It's about the individual. It's their choices. So now we're going to get into this. The ROP talks about multiple areas with regards to customer satisfaction, and that's one of the objectives. Remember this, person-centered care is a path to high client, resident, patient satisfaction, but you also have to understand the concept of what is a person's satisfaction. It is the difference between expectation and reality. So I go to Jose to cut my hair. He's from Puerto Rico. He just got back from Paris. He said, Chris, I learned how to cut your hair with a razor. Oh, great, Jose, that sounds great. He's like, I'm not going to wash it. I'm just going to use a razor. Would you like a glass of champagne? Absolutely, 7 a.m. 6 weeks later, he does it, comes out great. 6 weeks later, I go back. He washes my hair. He uses scissors. And he offers me a glass of water. Now, I will tell you, the haircut came out the exact same way. But in my belly, I didn't feel as though it was the same. Why? Because it was not what I expected. I didn't expect it that way. So if you have a superstar nurse aide. And they're the ones that go in and they rub the feet and they put bag balm on it and fluffy socks to prevent the cracks. Is that good for your facility, or is it not good for your facility? Well, it's not, because if I have superstar Susie doing my bag balm, and then I get her for 2 weeks straight, and now Sally Sadsack comes in and she doesn't do the bag balm, I'm now dissatisfied with the service. A very tricky scenario, because you do not, well, the regression to the mean is the mathematical sort of outcome here, but you want to be sure that there's consistency. Now, the best thing that you ever got, and I know you're going to disagree with me, is that 48-hour care plan. Because you're like, man, if they come in on a Friday, I have to now come in on a Sunday to go in and tell them the 48-hour care plan. Why is this so good for you? Because you see, if I'm admitted on a Friday and Saturday rolls around, I really don't see anyone, and Sunday, now by 2 o'clock, my 4 daughters are calling me going, what's happening? What are you going to get out of there? Are you going to make the christening? What's going on, Mom? And I know nothing. But because of the 48-hour care plan, you have to come in and say, hey, Chris, good to see you. You got X, Y, Z. Tomorrow morning, OT is going to come in to do activities of daily living. You're going to, we're going to do a big meeting on Tuesday. We estimate that you're going to be here for about 8 to 10 days. Great. My mental anxiety now is addressed. I'm acquiesced. I'm like, okay, great. I now have a plan. Communication to the resident. And by the way, one of the 7 trainings is communication. And that is a product of them looking to say, hey, how are you communicating within your organization, especially with all these automative, advancements, IT, information systems. People are no longer handing a medical record back and forth, having an impromptu dialogue. Everyone's sitting behind a terminal. So the point is that this information that's being provided to the patient is going to be mandated, it has been for 48 hours. Then you're going to do your more final care plan. Now, understand, prior to long-term care, I worked in a rehab hospital, and that is common practice. Within 72 hours, there was a family meeting. This was our system. That communication is important. One example I'll give you, just another anecdotal comment example. There was a facility, and this is years ago, and they had a very compressed length of stay, and they sent me in to analyze it. And one of the 15 reasons why was because when the physicians discharged the patients from the hospital, they would say to the patient, oh, you're going to be there for 5 to 6 days. Well, when they come in, everyone evaluates and they don't agree, but it doesn't matter because they already told the patient, you're going to be there for 5 to 6 days. So they were running out the door. Now, this situation is not good for you because under those QRPs, you also have the return to hospital, return to community. If a patient leaves you within 30 days, if they go to the ER, the hospital, ideally they come back to you because you're calling them and really looking at this post-acute care transformation and how they go along after the hospital, they go to maybe an IRF, an LTAC, a SNF, home health, outpatient, whatever it may be. But it's not in your best interest for that patient to go back because the perception will be that you did not properly care plan and effectively have a safe and effective discharge. So rushing them out the door is not in your best interest. So we keep going on. So we're on number 4 and we have 21 minutes. We're going to make it, don't worry. And let's see, we talked about the PHE. This is very important. The public health emergency could technically end, and something could have come out in the last 2 days. I've been in South Dakota. I just got back to Boston. But the PHE is your friend. You want the PHE. And the reason you want the PHE is because, like those managed Medicares I mentioned, there is no 3-night hospital stay, which is, you know, we should be lobbying and advocating to get rid of the 3-night qualifying stay for traditional Medicare, because technically that is a very big advantage a managed Medicare has on you for traditional. Another discussion, but PHA, we're going to roll really fast. There are two, because of the PHA, you do not need a 3-night hospital stay. And I'm also going to ask you about your Medicare Part A coverage criteria knowledge base. If I have, we're going to talk about COVID for a second in that context. Isolation, quarantine. They have two different definitions. Isolation means that I have a positive COVID diagnosis, and I will be I will be isolated away from people, and people that enter the room will don and doff PPE. Isolation. I have been exposed. Regardless if I have quarantine, regardless if I have symptoms, I have no positive diagnosis, so I am quarantined. In both these instances, isolation, quarantine, the daily skills, knowledge, and judgment of a nurse are required. Isolated, observation and assessment of proper infection prevention policies and procedures, application, exacerbation of COVID, and conditions and diagnoses that evolved or exacerbated secondary to COVID. Quarantine, observation and assessment of signs and symptoms of COVID. Observation and assessment of signs and symptoms of other conditions that worsened or arose secondary to quarantine. Both of them, skilled nursing for implementation of effective infection prevention protocol. Now, the CDC thought they did you a favor, and they said, hey, if you have 2 COVID positive patients and you need to isolate them, you can cohort them. We're going to be okay with that because we know you've got stuff going on. Well, not good, because on the MDS, if you cohort, it is not considered isolation. It is considered isolation from a CDC clinical perspective. Quarantine. You can quarantine 2 individuals that were exposed. Big mistake. Why? One that was exposed could be positive. The second one who was exposed may not be. So you're now putting yourself at risk for spreading it. You do not have skilled nursing facilities across the country do not have structure. The New York Times said in April 2020, nursing homes are not built to handle COVID. Yeah, for multiple reasons. Number 1, you don't have single rooms, most of you. Number 2, you do not get paid enough. In other words, you can't possibly run your business getting paid the Medicaid rate, which in New Hampshire is lower than what the prisoners' PPD allocation is. And you have it's a complete abomination of, you know, the system. They need to pay you more. They need to, and your PDPM, yep, went up a little bit. Don't yippee-yay, because it's still not far enough that you need to run your business. But isolation and quarantine, understanding what is skilled. Well, you might say, well, wait, Chris, I saw something. It was written down. It said we can't skill quarantine. Now I'm going to give you my opinion on that. There are 4 pillars of skilled nursing. Number 1, observation assessment. Observing and assessing for signs and symptoms related to X. Regardless if anything happens, it is skilled if there's a likelihood or reasonable probability. Number 2, education and training, self-insulin, teaching someone how to do self-administration of medications, colostomy care, stump wrapping. Number 3, overall management care plan to ensure medical safety and promote recovery. And number 4, inherent complexity, IV meds, IV fluids, vent, trach, suctioning, etc. The quarantine patient falls under the observation and assessment, in my opinion. And this is my example. During the pandemic, I'm all over the country, I get calls. They're dropping like flies. Okay, they're dropping like flies, and they had no symptoms. What is a fever in a nursing home? Think about it. A fever is a 2.4 degree Fahrenheit change from baseline. So my dad was exposed in December of 2020. I was wild. I said, as soon as I found out, I said, every 2 hours, send me your temperature. 96, 96, 96, 96. We ultimately get him tested, and he's positive. 96, 96, 96, 96. I even have the professional thermometers that you have the thing on it, you push the button, pops off. So now on the Wednesday, tested on a Monday, Tuesday positive, Wednesday. Doctor emails, would you like to try, we're now merging into January of 2021, the IV bambolimolin? And I reply, yes. I don't care that it's not FDA approved, run. Dad's 86, status post myocardial infarction, diabetes, poor kidney function, poor lung function, yabba dabba do. 96, 96, 96, 97, 97.5. Days are going by. 98, 98. Now, this IV doesn't arrive from the Wednesday email until Monday. Sunday, he's hot. His fees up there. Monday, 99.9. Tylenol will not touch it. 4:30, the cooler comes with the IV meds, take it out, defrost. Nurse comes at 7:30, administers 8:30 to 10, 10:30. It was 99.9. By Wednesday, he was 96. This was in January. Within 2 weeks later, I think McKnight's did an article on this IV and the miraculousness of it. My point is this. A week later, an ICU nurse says, well, he never had a fever. Yes, he did. His baseline is 96. A 98.4, which is a 2.4 degree Fahrenheit change from baseline, is a fever. Only the long-term care experts would know that. The daily skills, knowledge, and judgment for that quarantine patient are required to observe and assess, because then if you don't put them on Medicare Part A, you are being remiss, because when you put them on Medicare Part A, you immediately put into gear certification, daily notes, shift notes, utilization review, Medicare meeting, whatever you call it. You're putting in motion great care. Now, during the pandemic, I traveled the country. I had the essential worker. I went into, and I would walk in, I'm like, look, being in a private room, an isolated room, if you can do it, we're going to do it. It's the best for the patient. Now, yes, if you have isolation and you're positive and you're by yourself and not cohorting, you can get up to 13, 14, 15, 1600 for the first 3 days of Med A. If you don't have that, you'll fall somewhere under the PDPM nursing component, but you're still skilled. And there's buildings that their revenue shifted by 440 to 500,000 a month. Okay, good care, accurate reimbursement. So that is my discussion on the PHE. Person-centered care is what is behavioral, trauma-based. It's about them, making sure it's in the care plan. Bigger, deeper than that. I'm not going to get to capitalizing community. Therapy minutes. I am an OT. Prior to PPS, we treated 1,200, 1,300 minutes. Do not let anyone tell you that 720 minutes is a lot. It is not. 720 minutes means that PT and OT, not speech, treated Monday through Friday, 5 days, 72 minutes each. Is that a lot or a little? Well, it's a little in my eyes because I walk in to do my ADLs. I will do, when I walk down the hall, CNAs are high-fiving me, because when I do an ADL as an OT, I'm just doing the waist down because they're a fractured hip. No, I'm looking at the whole person, and I'm looking at problem solving. I'm looking at cognition, attention to task, retention, memory, everything. And if I just see that patient at 6:30 a.m., I would be remiss if I didn't see them in the afternoon, because what if they sundown? So an ADL will take me between 35 minutes to 90 minutes. So if an RU is 72 minutes for PT and OT each, 5 days, it's not a lot. Number 5 is saying, do not let the reimbursement tail wag the dog. Because if I were the government, I would look at your minutes from 2017 and 2018. I would not look at 19, and I would not look October 19 when PDM first came in. I wouldn't look at 20 because it was a pandemic, and I probably would give you a pass on 21. But in 2022, I'm going to be looking to see, what are you doing? And what are you doing? Because if you're doing anything less than what you were doing before, I'll have concern. Furthermore, you have a staffing crisis. The more hands on deck to have patient interaction is to your benefit. Number 3, well, I'm not bringing them. OBRA 87 mandates, the Omnibus Reconciliation Act of 1987 mandates that you ensure patients maintain their highest physical, mental, and psychosocial well-being. It is not okay for me to come into your facility and run a marathon and 6 months later be a 2-man assist. It's simply not. So if anyone changes, whether it's depicted on the MDS or not, you need to get therapy involved. So if I'm going to say 2 suite therapy minutes. Now, number 6, we have final rule. Okay, great. You had the final rule. It comes out every year. You got a bump in your PDPM. Stuff's going on there. You got to know a little bit about it. But you've got ROP. ROP is your focus, because the surveyors are coming in, and you got to know how to write a plan of correction, and you got to understand QAPI, because QAPI is their focus. Every tag that you get, you should QAPI. And specifically what you should QAPI is, what is your audit function? The audit function, so for example, a building, patient leaves via a van with the wife, goes to a doctor's appointment. Doctor's never met this patient before. The doctor says to the wife, he looks a little peaked. Could you bring him downstairs to the emergency room? Because I don't know, he doesn't look good. She says, yes, sir, 6 bagfuls. She leaves, puts him back in the van, drives 25 minutes to Kaiser Permanente. Her husband dies in the van. Oh, it's an immediate complaint, of course, it's an investigation. Well, the plan of correction is that for a period of time, every single patient, prior to them leaving for an appointment and coming back, there will be a nursing assessment. So to ensure that this prevention, right? Well, I say to the facility, I need you to QAPI the QAPI, meaning I want the administrator to go to the monthly QAPI, I know it's quarterly, but monthly, and say, the pre-departure and post-departure nurse assessment was completed this month. That's what he's reporting on, he or she is reporting on. Well, in this, it was a man. The DON is going to report that, and we did the audit, and we were 90% compliant. 9 out of 10 patients that left had a comprehensive nursing summary, and 8 out of 10 had the return. And we've identified the nurse, educated the nurse, blah, blah, blah. So QAPI your tags. Make sure that you identify make sure that you Do not let that audit fall off. It is the number one error that I see. You say you're going to do something and you don't do it, and the worst thing that's going to happen is you get tagged for the same thing you got tagged last time, and that's not good. So as you can see here, I have PDPM. I have the word final rule, PDPM. PDPM, you have not learned it. You may think you have. There's a great calculator that we use. It's free. It's the Hub Force PDPM calculator. There are 41,000 different combinations. We're talking, we came from 66 combinations to 41,000. There is opportunity up the yin-yang. Like, it is unbelievable. PDPM put the nursing back into nursing homes. It is awesome. It's going to highlight nursing. Nursing is complex. You want to be sure that you are coding the MDS accurately. You want to be sure that you understand the fundamentals of skilled care. PDPM is in the top 8. Now, the COVID-19, skilling, quarantine versus isolation, it goes deeper than that. Do you understand skilled care? You now have only so many months while the 3-night qualifying stay is not mandated. And if they take it away, you will not be so readily available to skill. So that's where I'm going there. Efficiency, census. The census component is, don't forget to look at the back door. Fill your beds, collect your money, give good care. Fill your beds is census. Now, if they're going out too soon, if they're leaving, and you're at risk for the return to community, you're at risk for the rehospitalization. Rehospitalization should be copied. You should be looking at this. It's an easy miss. Keep the beds filled and have safe and effective discharges. Staffing crisis, my 30 seconds on staffing crisis is this. People leave not because of money. They leave because they do not like their boss or what the boss allows them, other people to do. Get rid of bad apples. Do not tolerate C2H4, which is ethylene. If someone's doing behaviors that are not acceptable, call them out on it. Like if they're calling out sick, the next day, sorry, we missed you. Because you were out, Chris had to work a double shift. We're so glad to have you back. Do a survey monkey. Find out what's important with your existing staff. It could be uniforms, free lunches. I don't know. Don't presume or assume that you know what they want. Work on the existing staff and it will come. Number 8, survey. Facility, I have 3 minutes. Facility assessment. It is the most important thing. I will go into buildings and I look at the facility assessment. It's bejangled. And what I mean by that is you hand this to the surveyor when they come through the door. It has got to be beautiful. And it has to be all in one document. It can't be, I got something here, I got something. No, it's going to be incorporated. I tell all of our clients, get their facility assessment and type it. It's super important. You are handing this and it's the image that you get. With that, back to PBJ. That building that I told you about, that sexual assault, number 1, it wasn't them. 4 months afterwards, the investigation showed it wasn't them. Their facility assessment was bejangled, and because of the sexual allegation, they did not submit their PBJ. So they had a 1 in that domain. When the surveyors came in, they had a bejangled facility assessment, and they had a 1 on their PBJ. So they assumed that they were understaffed, and they were not understaffed. They were eloquently staffed and complementary staffed because they had vents. They had respiratory therapy, which, sidebar, lobbyists, respiratory therapy hours do not go into your PBJ. It should go in. Respiratory therapy, like PTOT and speech, is another added value. I get it. Even despite the fact that it doesn't go into the PBJ, it's another set of expert caring hands. So to give great care. Now, vaccinations, infection control. What is the number 1 citation on infection control? Drum roll, hand washing. 20-80% principle. Hyper focus on hand washing. It's the number 1 biggest cause of infection, and it's something that you can monitor and teach effectively and efficiently. Senior CNAs, senior nurse aides, I had 2 clients, same big owner. I'm doing infection control in 2 different buildings. One of them had such a better system. I didn't know it. Figured out why. Because the one that had the better system was the one that had the seasoned CNAs. And seasoned CNAs, nurse aides, will look over to a newer one aide and say, hey, don't forget to wash your hands. But in the southern building, there were a lot of retirements of CNAs because they didn't want to get the sickness. This is during COVID. They didn't have that. Capitalize on your high-ranked CNAs to nurture and on the floor monitoring. Hand washing is number 1, and of course, last number, QAPI. QAPI is everything. We can do a huge discussion on QAPI. QAPI is imperative for you to do your plan of corrections. It's proactive, not reactive. Be sure that you have notes. They're specifically looking for you to train your staff on the components of QAPI, and they're specifically looking at how you derived the formula, the calculation for whatever metric it is that you're focusing on. So I have met my 60-minute mark, and I adore Pennsylvania, and I hope that you guys have a great weekend. Thank you for having me. My name's Chris. You can email, you can text, you can call, and I'm going to see if there are any questions.
Thanks, Chris. I'll pick this up here. I opened the Q&A icon. I'm not seeing any questions. If anyone does have a question they'd like to submit right now, they're more than welcome. Otherwise, you're more than welcome to reach out to myself or Chris with questions that might arise after today's session. As a reminder, we will be sending out certificates for this course in about 2 weeks, and the recording will also be made live on our website, also in about 2 weeks. So if no one has any additional questions today, I thank you so much for Chris for presenting. You did a wonderful job, and I hope everyone has a great weekend.
Thank you, everyone.
Thank you.